This will be an interactive session. We have a panel. Assigned, but I would really like to open it to everyone as well in the audience to come and be quite interactive. So let me start now, and I will ask you questions as we move along. So the first case is pretty straightforward. This is a 71-year-old man who developed episodes of a cold feeling in his chest lasting 10 to 20 seconds that over the course of 6 weeks increased from happening once every other day or two to several times per day. And this occurred last summer, starting in mid-July, so that by the beginning of September, he was having this 6 times a day. There was no associated movements with these feelings of a cold feeling in his chest, and he had fully preserved awareness. He just had a cold feeling. His doctor saw him and thought this was seizures and gave him lacosamide. Any thoughts? Does that sound reasonable? A cold feeling in your chest for 10 or 20 seconds? Would you start lacosamide? Yes, in the USA, it's also, I should comment, lacosamide is about $1,000 a month to prescribe, so it's rather expensive. It's a rather good drug as well, but it's expensive. And he was not my patient at the time. No objective signs whatsoever. No change in that. Just it was very stereotyped sensory phenomena, and his doctor, who was a very good doctor, Joyce Liparachi, thought it sounded like seizures, so she gave him lacosamide, and the symptoms stopped. His electrocardiogram was normal as well. And as you can see, he had an interictal EEG that was normal. However, 2 weeks later, he developed symptoms, and then I wound up seeing him. In fact, he was at the end of this period where he was treated with lacosamide and the symptom stops. Right at that time, he was admitted to the hospital, had his EEG recorded for 24 hours, and nothing occurred. 2 weeks later, he developed new symptoms. I'll show you the video. And this was occurring many times per day. I would say, what's that? MRI? We don't use MRIs. We use lacosamide. His MRI was normal. ECG is normal. MRI and ECG are normal. So 2 weeks later, he developed these symptoms many times a day. I would say, in retrospect, thinking out about it, probably 100 times a day or more. What was noticed was perhaps 10 times a day.
Mr. Lee, I'm Dr. Sperling. How do you do?
How do you do?
Nice to meet you. Is that it again?
Yeah.
Nice to meet you.
My pleasure. It's my wife, Leanne.
Hi. Nice to meet you. Let me just tell them
Let's go back. Let me go back. Watch it again, and I'll point it out.
Mr. Lee, I'm Dr. Sperling. How do you do?
How do you do?
Nice to meet you.
That was
Is that
it.
it again?
Yeah.
That was it. I'll show you one more. Here it is again.
Me again. Hey, sorry to keep coming into me. Quick question about your PIC line. I know I looked at the dressing to see if it was... Oh, there you go.
That was it. Lasts a second or so. So you say... So we're saying what's being proposed that these are seizures, fatiobrachial dystonic seizures. FBD is the abbreviation that was used. How many people? Yes. So this is the question. So it's actually not provoked by sense or touch, though. It can happen. It just happens spontaneously. And she touched him when it happened there, but often he's just...
support to help us with microphone, okay?
Yeah. So, but often it happens without any touch. But let me put this to you. This lasted 1 second. Is that compatible with a seizure? Do seizures last 1 second, or is it myoclonus or a tic? So it's a bit Yeah, so it's a bit sustained. It's a bit sustained for myoclonus. He kind of goes like that for, I mean, it's a second. It's not a fraction of a second. So by show of hands, how many are firmly convinced that this is a seizure? This light is right in my eyes. I can't see a thing. By show of hands, hands held high. Okay, so we don't have that many people. How many are not sure that it's a seizure and think it's probably not a seizure? So we have as many hands going up saying it's not a seizure. Okay. But this is indeed a seizure. So the usual rule of seizures is that they last 10 seconds or 20 seconds or a minute or two. But the weird thing about fatiobrachial dystonic seizures is that they're very brief. They can be as brief as a second here or only a few seconds long. This fellow, his EEG was utterly normal during this. During the symptoms, it was normal. Interictally, it was normal. His MRI is normal. And the diagnostic test that we did was the voltage. Initially, you get a useless test, which is the voltage-gated potassium antibody channel. It was markedly elevated, but in fact, this has nothing to do with the voltage-gated potassium antibody channel. It's a cross-reactivity. And really, it's LGI-1. And LGI-1 in this fellow was positive in CSF and serum, and the Casper-2 antibody was negative in CSF and serum. So these are potassium channel associated antibodies. And he had this again being America, he had the full panel, even though it cost a lot of money, but we were sure all other antibodies are negative. So question is, how are you going to treat this man? And what is your evidence base for this? So maybe someone on our panel would like to offer an opinion. How are you going to treat him?
The episodes respond to immunomodulation. So you can give them 3 anti-epileptics, 4, they're not going to respond. But the moment you start immunomodulation, they are going to respond. So it's one of those immune-related therapeutic.
So what you're
epilepsies.
saying is that this person with seizures, you're not going to give anticonvulsant drugs to.
No, you will give them anticonvulsants.
You just said they don't respond.
You will give them anticonvulsants, but the response is to the immunomodulation. Yeah.
So how are you going to immunomodulate?
I'd first like to give him intravenous methylprednisolone, and
How much?
1 gram a day for 5 days is what we use, followed by oral steroids.
For how much and for how long?
But then being elderly and he may have comorbidities and bone issues, so you will like to augment it either with immunoglobulins or other immunomodulators associated.
Okay. Yeah. So it's very interesting. The studies show that anticonvulsant drugs really don't work in this population, and I think one could really say that anticonvulsants probably play a minimal role. As Dr. Tripathi said, she still gives anticonvulsants because she's an epileptologist. I do as well. And in fact, this person initially had symptoms that transiently responded to lacosamide, but they really aren't sustained. So, data published in a nice paper from Irani showed that the medication really doesn't work, but the response is quite good to immunomodulatory therapy, the IT, as opposed to anti-epileptic therapy. And typically what we would do is give IV steroids, usually we would give 3 days of IV solumedrol, 1 gram a day, and also intravenous immunoglobulin, 2 grams per kilogram total over the course of 5 days. And then what would be recommended, and in fact for this person I just emailed Joseph Dalmau, who's a friend of mine, seeing what he's doing lately. And Joseph is recommending these days 3 days of IVIG and then 2 months of IV steroids, starting at about 80 milligrams per day of prednisone and taking away 10 milligrams per week, so a 2-week course. This man stopped nearly completely within 2 days. So by the second day of solumedrol and 800 milligrams per kilogram total of IVIG, his seizure stopped entirely. And then he had the 2 months of steroids. And what we'd like to do is continue IVIG for a little bit longer. And that's somewhere from 3 to 6 months. There are no good prospective studies where people have been randomized to therapy. Any other comments or questions? Yes? I'm sorry, what's that? Use the microphone, please.
in this case. What about chest tightening, which appear and responding to lacosamide before attacks occur? Chest.
So the cold sensation?
Yeah, the cold sensation in the
Yeah.
chest.
So I think the cold sensation was a manifestation of seizure in his case.
Merci.
And it was not possible to make a diagnosis at that time. It was not typical behavior for the LGI1 antibody. It was not the facial-brachydystonic seizures. What's that? Yeah. So you could call this, yeah. So you could call this an autonomic aura, but it's interesting. When he had his movements, he no longer had the cold feeling. He only had the movements. Right. Yes. Yes.
The EEG was normal at first. Did it become abnormal when you looked at his seizures? Here it says frontal temporal or frontal temporal, but our patient had a normal EEG last time we knew about it.
Yeah, so our patient had a normal EEG during these attacks. The EEG did not show. Now, scalp EEG, with an intracranial EEG, one might see something different, but scalp EEG was normal. Any other comments or questions? Yes, use the microphone.
Did he have any autoimmune disorders?
He had no history of any autoimmune disorders whatsoever. Perfectly healthy. So now he came back to see me, and I saw him a few weeks ago, so it's been 4 or 5 months. The question is, should I leave him on anticonvulsant therapy? How long do I maintain that? Yes.
Can I make a question? What about the follow-up? What is your routine? Should we make antibody levels? Should we make EEG, sequential EEGs, or sequential diffusion MRIs to check if something's going wrong before the clinical features comes to us, or we just follow them with?
So the evidence is, good question. So the evidence is that we just follow them clinically. Repeat antibodies appear not to indicate very much. You can do follow-up antibodies. The titers can be higher or lower. It does not appear to correlate with response to therapy. And EEG was normal when he was bad. To continue getting EEGs, I think, would serve no purpose. As far as doing follow-up MRIs, again, there's no evidence that it's going to make a difference. So the general recommendation would be a clinical observation. And usually this is a monophasic illness. For most people, you give them a course of therapy, and then they're better, and that's that. Some small percentage of people will relapse, and then they will need a repeat treatment with immunomodulatory therapy. Yes.
Regarding treatment, if we consider these seizures as acute symptomatic seizures, we could stop the treatment after a few weeks. If we consider that the inflammatory disorder has disappeared, we may not need to continue treatment on a chronic basis.
Yes. So that's a good point. It's probably an acute symptomatic seizure from an immune response, and no one has done long-term studies, but there are some patients who have been treated very briefly or not at all, and others who are given anticonvulsants, and it appears that probably anticonvulsants don't really play a role. So for this therapy, when I saw him, I tapered him off of drug, and he was instructed to call me should his symptoms relapse. It's been about 3 weeks. He has not contacted me, so I'm assuming all is well, but time will tell.
Stupid question. Why does he have seizures?
Why does he have seizures? It's not a stupid question, it's an excellent question. So he has LGI1 antibody, which preferentially attacks the limbic system, which is why the EEG is negative, because these are deep-seated foci, and they're very brief, and there's not the time to spread out. And
do you know why it hits the limbic system and not anywhere else?
No. Why LGI1? I mean, the target appears to be somewhat more concentrated in the limbic system in terms of the autoimmune target, LGI1, but there's not really great explanation. So when you look at rat brains to see what the distribution of antigen is, the distributions seem to be higher in limbic system. So but why is that there? It's very interesting. I mean, why do NMDA receptors also preferentially attack the limbic system, yet we have NMDA receptors everywhere throughout the brain? So there's some special cross-reactivity. Probably these people do not need to be treated for more than a few months. I would somewhere in that 3 to 6 months range. If there's relapse, we would do another single course, and then they get better. Let us move forward. Case 2, 28-year-old woman with a history of tonic-clonic seizures starting at age 17. She has no aura whatsoever. Sudden loss of consciousness with bilateral tonic and then clonic movement lasting 1 to 2 minutes. Her seizures typically occur in the morning within half an hour of waking. At age 17, she was begun on lamotrigine after the first seizure, and she still had seizures at a rate of 2 or 3 per year. This went on for 3 years, and then she was switched to levetiracetam, and she continued to experience seizures at a rate of 2 to 4 per year. At age 22, she was switched, not added, Martin, but switched by me to valproate. So she was still having seizures on levetiracetam. When I introduced the valproate, I pulled away the levetiracetam. So I was not faced with the problem of having add-on, now she's doing well, do I take away the second drug? I had her only on one drug. So these are actually 2 approaches one could use. You can add a second drug in, see how they do, and then pull away the first, or simply do a substitution, and I think you're less likely to have that problem of now I'm on combination therapy in a young woman with valproate. It's another way of handling it. Because I agree with you, when someone is doing well, it's very difficult to rock the boat. So then she was switched to valproate at only at 500 milligrams per day, and then seizure-free for 4 years. However, at age 26, she moved. Americans move an average of every 5 years. No, it's true. There are studies. Americans move an average of every 5 years, except when they're younger. Myself, between the age of 21 and 28, I moved 8 times, personally. Not always to different cities. There were 3 different cities, Philadelphia, New York, and Los Angeles in my case, but we kept being thrown out of the apartments we were living in. My wife is very wild. But at age 26, she moved, went to see a new neurologist who said, you're on valproate. You're a female of childbearing age. You should not be on valproate. So even though you've been seizure-free, I am stopping your medication. And he put her on oxcarbazepine because of the fear of teratogenicity, and she promptly resumed having seizures at a rate of 2 or 3 per year. And she is now 28. She comes to you in your office. She has no epilepsy risk factors. Family history is negative. Her examination is normal. And here is the EEG. So what does the EEG show, everyone? She's got generalized spike wave, and we knew from the history of seizures all starting within half hour of waking, she probably has idiopathic generalized epilepsy with grand mal seizures on waking. Her MRI is normal, of course. She got married, which is why she now came to see us, and she's not very happy with this doctor who put her on a new drug, oxcarbazepine, and now she's having seizures. And now, how would you manage her? Maybe Thanos, do you want to? Can we pass the microphone over?
To start with, it was wrong that sodium valproate was changed and was stopped. Because sodium valproate at 500 milligrams a day has not so much higher risk than other drugs in pregnancy. So it was wrong, that movement. If I had seen this patient some years later on oxcarbazepine, I was going to put her back on sodium valproate. Because what happened at the first EEG is that although she had a generalized tonic-clonic seizure, it seems to be an idiopathic generalized tonic-clonic seizure. And I'm not sure if the EEG, the first one, it was a sleep-awake EEG or it was only an awake EEG. Because
she was awake and asleep with it, but you can see she had this burst.
So I think that if I was you, I was going to put her back on sodium valproate, 500 milligrams a day.
So you would take this woman who
unless you will tell
wants
me,
to get married, who is now just married and wants to start having children, and put her back on valproate.
Discussing with her, and not only in addition, I will put her to sign that she agrees to go on valproate.
Okay. Any other comments? Let's pass the microphone down.
You can use this microphone. Sorry, sir.
Use the microphone.
How is it?
I would discuss with her not only teratogenicity, but also the cognitive outcome of the baby. And at 500 milligram, I think it's all right to continue this dose if she's well controlled, being a primary generalized epilepsy, to continue 500 milligram. We know that the effect on cognition of the baby would be at high doses. So this is another point I would like to discuss with her and continue her on valproate.
So you can discuss with her, but ultimately she says, doctor, what do you recommend?
I would
So
recommend.
what do you recommend?
I would recommend valproate because you're well controlled on it for 4 years, and we've seen the effect of changing the medication.
So same as Thanos.
I was my professor same treatment. But my question, why first treatment in first seizure, lamotrigine? You are treated first seizure?
Her first, I mean, she was put on medication after the first seizure in her case, with lamotrigine, as you can see.
Don't wait to another seizure. Treated first. Don't wait to another seizure to treat. To start treatment. You understand?
So you're questioning why was she treated after the first seizure? I mean, I wasn't there. She was. I think many of us would argue that with idiopathic generalized epilepsy, adolescent onset, the probability of a second seizure is quite high, greater than 60%, and it's reasonable to treat. Some might choose to wait, but I think it's reasonable to treat after a first seizure. In fact, probably half of people who have one seizure are going to have a second if you wait long enough. Martin.
Yeah, I think, we treat, usually the EEG is abnormal, and that's why you treat, and there's occasional jerk or something, and after first seizure. But I think in the current setting, if she's, obviously the Oxcar has to go. It depends on how much of a hurry she is. If she's not in a hurry, I would certainly try lamotrigine and levetiracetam before you go back to valproate.
She had levetiracetam and had seizures on levetiracetam.
Right. In that case, I would try lamotrigine before going back to.
She had lamotrigine and she had seizures on lamotrigine, and she had seizures on oxcarbazepine.
Yeah, well, you're stuck then. You're back to valproate. I wrote a paper on this recently, and we've even tried perampanel. We try anything, because the girls don't agree to go back on it. Once they know the risks, they don't agree to go back on it, and that's the biggest problem for us. It's on your conscience when you're treating these kids, when you know a small dose of valproate is going to solve the problem.
Yeah. But again, the risks of a small dose of valproate are exceedingly small, probably no greater than the risks of lamotrigine or levetiracetam.
I would take it, and you would take it, but she won't take it. That's the problem. The patient often says, "I'm not risking damaging my baby," and that's it.
Eleanor?
Yeah, I would give her the valproate at 500 milligrams, but also add folic acid, which is a recommendation of the AES, AAN, 5 milligrams, and pray.
And a multivitamin as well.
But we're part of the Europe Epilepsy Pregnancy Registry, and we looked at our 300 patients that we've had during the year, and we have, during the years of about 15 years, and we have consistently add folic acid. I have no idea if that's the reason or not, but during all the years, even with our patients on valproate, most of them had low doses. We've only had 3 teratogenic episodes.
So we went back and looked at our data in over 100 patients, and once they had failed 3 drugs other than valproate, nothing else worked. Valproate works in some of them, nothing works. In fact, after they had failed 2, it was incredibly rare for anything to work other than valproate if they had generalized epilepsy. So I think what we're seeing here, which is very interesting, is that our experts in the front row and our experts in the rear have not spoken mostly, although Eleanor's in the second row, all want to take a woman who wants to have a child and use low-dose valproate. And that's really the purpose of this case, that valproate has been put out there. And in fact, 2 or 3 weeks ago also, I was doing a lot 2 or 3 weeks ago. I was seeing the man with LGI antibody, and then Saturday morning I was exercising in my home gym, which is simply an elliptical machine with a television in front of it, and a BBC documentary came on the evils of valproate, a half-an-hour BBC documentary about how doctors are mistreating women with valproate and what a terrible drug it is. I'll tell one other story. I once had a young woman come to me with her new husband. They had been married a short while. I'd never met him before. I'd been treating her for a long time. She had a similar story. She had failed treatment with several drugs. She came to me. I had her on low-dose valproate, and she'd been seizure-free for several years. And then she'd gotten married. They wanted to have a discussion about having children. It wasn't going to happen instantly, but they were planning to start it in a few years, and they wanted to make plans. And we had the whole story, and I discussed the risks of valproate and the fact that, of course, she had already failed 3 or 4 different drugs before going on it and then doing very well. And then, not having been married very long, he made the mistake of speaking first. He said, I think we don't want valproate. And if looks could kill, if eyes could shoot daggers, hers would have shot it at him. She looked at him and said, you are not the one who ever had a tonic-clonic seizure. It was horrible. She had a laceration once. She could have hurt herself badly. And I find that when presented with, it depends how you present the facts, but people are not so unwilling when you present the facts. Ettore, where's the microphone for Ettore? Oh, I'm sorry. Sorry, someone else.
I was just going to say that in this particular case, and this is anecdotal, and you can't extrapolate to everything, but this particular woman is very lucky because she's very sensitive to valproate. We all agreed that she probably should go on that because the risk of having a mate, she has generalized tonic-clonic seizure, so the risk to the baby and the pregnancy is quite significant. And the skill we have to use is, even though she might say, what do you recommend, is for you to actually draw her to make the same conclusion so that she's on side. And what I normally do is when I've discussed all this, I send a copy of my letter that I've sent to the referring doctor to the patient. So I've documented what we've described about and the fact that she and I have come to the same decision.
Good suggestion. Can we pass the microphone forward, please?
It's me here, Ilan. Yeah, I know
Two
it's
lights
blinding.
in my eyes,
That's right.
They're utterly blinding.
Can I interject something? We have discussed this case before, remember, and I thought before putting your back on valproate, how would people here feel about a trial of zonisamide? Just to say that zonisamide was reported before as having a risk of low birth weight, small for gestational age, along with topiramate. But then in the last version of the North American pregnancy registry, it comes out very good. Although the numbers are pretty small, it appears very good, comparable to levetiracetam and lamotrigine. So the question is, what is the likelihood of her being seizure-free on zonisamide, having failed what she has failed? And would people here try this drug before putting her back on valproate?
So, I can answer from my personal experience, probably having used zonisamide in at least 40 or 50 people with not only women, men as well, with idiopathic generalized epilepsy who have failed several drugs. I have never had it make someone seizure-free. So if it works, I think the probability, in my experience, is less than 5%. And it's a very low probability. Has anyone else seen people who have failed multiple drugs magically become seizure-free forevermore on zonisamide? Sorry?
I was wondering if you could decrease even further the dosage of valproate.
That's a good question. Question is, how low do you want to go if you have someone on? Is there data saying that 400 is significantly better than 500 for?
We don't know.
We don't know.
And obviously, the more easy way to go is to reduce to 400, 200. But I wonder if less could be even used.
It's a good question. You then have to say to the patient, I'll take Martin's view that he expressed before. You have someone who's seizure-free, who's doing well on a very low dose. Do you want to risk it by going lower?
It might be a discussion point with the patient so that you can say, well, we'll try a slightly lower dose and that gets you over that hump of making the decision to go back on. But as I say, we had a SUDEP in a young woman. She died at 22. She refused to take valproate. No matter what we said, what her family said, she wouldn't take it, and she ended up as a SUDEP and disaster. So it's not easy. It's fine if you can talk them into it, and we do our best. But if you cannot talk them into it, then it's on your conscience for the rest of your days.
Right. And then what I'm going to put up on this slide briefly to show is that there are consequences to fiddling with the drug. So this is far from a perfect study. This is by Ali Asadi Puya, a colleague of mine from his work back in Shiraz, not in Philadelphia. Just looking at how often people had problems with his population in Shiraz with seizures. So when you say, well, you're on 500 a day doing well, maybe lower to 400, you can see you set me up perfectly. What we find is with tonic-clonic seizures, there's a meaningful risk of injury from those. With other kinds of seizures, the complex partial or focal with impaired awareness, focal unimpaired awareness, myoclonus absences, the risk of injury is negligible. But tonic-clonic seizures are a problem. I've had 3 patients just in the last 10 years have a tonic-clonic seizure and have intracranial hemorrhages from a tonic-clonic seizure. And whoops, that's not that. So there's risk the other way. Yes?
I have a question. We know we have a patient who's exquisitely responsive to valproate. What if your next slide shows us 5 years down the line, she has a child, and the child has a low IQ and ADHD. This has happened in scenarios, and the mom comes back and now challenges you. Doc, you didn't tell me enough, and maybe I shouldn't have been on valproate because what the child has hurts her even more. So it's happening, and the low IQ and the ADHD could be due to something else completely different than the valproate. It so happens that she's on a low-dose valproate. So how do we tackle that?
Yeah, that's a problem because it happens anyway. So what we explain this in advance. Yeah, we have to end in 1 minute. So, and I'll give you a chance, don't worry. We have to end in 1 minute though. So yes, there is a risk anyway. The IQ data that is published from the NEED study has problems though. So, and the problem with the IQ data is that while the babies born to women on valproate had an IQ of 9 points lower than, for example, the babies born to women on phenytoin, the women taking phenytoin had a 6-point lower IQ than the women on, had 6 points higher than the women on valproate. So in fact, when you look at mothers, the mothers were 6 points lower, and then the children were another 3 points down, and you can see some fluctuation. So I think the IQ data is dubious. Learning disability, different matter entirely, and that's potentially a problem. But it also is potentially a problem with many other drugs, and there is no data on learning disability with zonisamide. There's no good data on long-term learning disability with topiramate. And you had a comment
Please,
back
the
to
last question from stable microphone, okay?
I would offer this lady a choice. There are several choices, all of which have the potential for rare but disastrous consequences. One would be stop her valproate and let her see how she does off of it, so she's not on any drug. There are risk of SUDEP and risk of injury. Another option is to, well, in any case, put her on probably 1 to 4 grams of folate per day, which will minimize the risk to some extent, not solve it. The next choice would be to put her on valproate and talk about the risk of teratogenicity. Another option would be try another drug, which is, I agree, is pretty low chance of working. But I think that this is one where you have to involve the family. They deserve it. They have the right to make that choice, and it's our job to present the choices to them.
Thank you. And just the last slide, and this is a paper by Professor Holtkamp's group, published in Epilepsy last year, that one of the sad things that we see in this condition altogether is that the proportion of patients who are seizure-free, so if you look at terminal seizure remission, greater than 5 years, this middle line, for the various generalized epilepsies is not enormously high. So this is really an excellent paper, and I recommend everybody read it. The first author's name is too long for me to pronounce. Forder Volkbecke. Okay, so it's Forder Volkbecke. But it's a good paper which tells us, even with valproate, we have a long way to go in treating these people. And we'll end here. We'll do another case session again at 5 o'clock after a series of debates in the afternoon. Thank you all.